60-year-old woman with known ER-positive, HER2-negative metastatic lobular breast cancer presents with progressive headache, diplopia, and gait instability over several weeks. An MRI shows leptomeningeal enhancement, and CSF cytology confirms malignant cells. She has stable bone metastases, but no parenchymal brain lesions. The prognosis for patients with leptomeningeal metastases, LM, from breast cancer has significantly improved over the last decade, similar to parenchymal brain metastases. Answer: false. Despite improvements in the prognosis for parenchymal brain metastases, the prognosis for patients with LM has not markedly changed, remaining poor, with median overall survival typically measured in months. Intrathecal chemotherapy is the standard primary treatment approach for leptomeningeal metastases from breast cancer. Answer: false. Systemic therapy and radiation therapy are increasingly used in the management of LM, with intrathecal treatment rarely attempted due to historic difficulties and limited efficacy. Leptomeningeal disease is a recognized pattern of metastasis, particularly associated with invasive lobular carcinoma histology. Answer: true. Leptomeningeal disease is relatively more common in patients with estrogen receptor-positive lobular breast cancer. Is combined modality treatment, example, systemic therapy plus radiation, associated with better survival outcomes in LM from breast cancer compared to single modalities? Answer: yes. A retrospective series found that combined modality treatment was an independent factor associated with improved survival in patients with LM from breast cancer. HR for death is 0.24. Can androgen therapies potentially provide benefit for leptomeningeal metastases arising from hormone receptor-positive breast cancer? Answer: yes. Responses of leptomeningeal metastases have been documented in case reports to multiple hormonal therapies, although they are typically used in conjunction with other modalities like radiation. Is the absence of concurrent parenchymal brain metastases a favorable prognostic factor in patients with LM from breast cancer? Answer: no. A retrospective analysis identified the absence of systemic metastases, meaning disease limited to the CNS, as an independent factor associated with better survival. This patient has known systemic metastases, bone. Their mere absence of parenchymal brain lesions alongside LM does not negate the negative impact of concurrent systemic disease on prognosis in LM.
A 35-year-old woman completed neoadjuvant chemotherapy followed by surgery for residual disease, then adjuvant T-DM1 for stage 2 HER2-positive breast cancer 6 months ago. She is concerned about her risk of brain metastases, having read about HER2-positive disease online. She is currently asymptomatic with a normal neurologic exam. Her treatment with adjuvant T-DM1, based on the Catherine trial criteria, eliminates her risk of developing brain metastases. Answer: false. The Catherine trial showed T-DM1 significantly reduced distant recurrence compared to trastuzumab in patients with residual disease, but there was no reduction in the risk of CNS as the first site of relapse, which occurred in approximately 5% in both arms. Routine CNS surveillance imaging with MRI or CT scans is recommended for asymptomatic patients like her with early-stage HER2-positive breast cancer. Answer: false. Routine CNS surveillance of asymptomatic patients with CT or MRI scans is not generally recommended, although a low threshold for imaging is appropriate if symptoms develop, particularly in high-risk groups like HER2-positive patients. The use of adjuvant trastuzumab-based therapy has been definitively shown to increase the absolute risk of developing brain metastases compared to no HER2-directed therapy. Answer: false. The relationship is unclear. While one meta-analysis suggested an increased incidence, OR 1.58, the overall risk was low in both groups, and the large HERA trial reported no increased risk of CNS as the initial recurrence with trastuzumab versus observation, 2% in both arms. The higher observed rate is likely related to increased survival and potentially a sanctuary site effect. Is HER2-positive subtype considered a significant risk factor for developing brain metastases in breast cancer? Answer: yes. Breast cancer subtype is associated with the incidence of brain metastases, and up to 1/2 of patients with HER2-positive metastatic breast cancer may eventually develop them. The risk is substantially higher than for luminal A disease. Does her relatively young age, 35 years, potentially contribute to an increased risk of CNS relapse? Answer: yes. Age under 40 years is potentially associated with an increased likelihood of CNS relapse, although it is often linked with higher risk subtypes like triple-negative breast cancer, and its independence as a risk factor is unclear. If she were to develop brain metastases later, would her prior treatment with T-DM1 influence future systemic therapy choices? Answer: yes. Prior therapy exposure is crucial in selecting subsequent treatments. Having received T-DM1 would typically lead to considering agents like tucatinib, capecitabine, and trastuzumab, or T-DXd if brain metastases developed and required systemic therapy.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.